Hello, everyone, and welcome to the IMA Weekly Show. I'm Dr. Kat Lindley, an IMA Senior Fellow in Family Medicine and Director of the IMA Fellowship Program. Tonight, we are pulling back the curtain on one of the most confusing and expensive parts of American life, buying healthcare. Most of us are told that health insurance protects us from high medical costs, yet families are paying rising premiums, meeting larger deductibles, receiving surprise bills, and struggling to understand what anything actually costs. You can shop around for a car, compare the price of a home, or check the cost of nearly any product before you buy. In healthcare, patients are often asked to agree to services without knowing the price, then receive a bill weeks or even months later. Employers are also paying an enormous share of these costs, often without realizing how much control they may have over the design of their health plans. Tonight, we are asking a different question. What if the best way to save money on healthcare is not to buy more insurance, but to learn how to buy care itself? Joining me, we have two guests tonight who understand the system from very different sides. First, we have Dr. Mollie James. She's an IMA Senior Fellow in General Surgery, a critical care specialist, and the founder of the James Clinic. Her integrative concierge practice combines conventional medical expertise with individualized care, root cause approaches, and patient empowerment. We also have Christine Price, who is the founder of High Stakes Healthcare. She has spent 30 years in the healthcare industry, including 22 years administering self-funded ERISA health plans. And for the past decade, she has built plans using reference-based pricing instead of traditional PPO network, and has challenged hospital billing on behalf of plan members. Dr. James and Christine, thank you both for joining us tonight.
Thank you.
Kat, thanks for having us. Happy to be here.
Thank you. Great. So let's just kind of dig in right away, right? Because everyone has questions about this. So first question goes to you, Mollie. From the physician-patient perspective, what have you seen that convinced you the traditional insurance-based model is failing to deliver affordable, transparent, and individualized care?
Yeah, I think this started when I was a surgical resident, and I asked the very basic question, how much is a CBC? And no one could tell me. Nobody could answer that question. Not the doctors I worked with, not anyone in billing, nursing. Nobody knew the answer to that. For those of you out there, it's $3 to $5 maybe. But if you look at the difference between what you can buy things for cash and what you get billed for, what you're told that it is, it's so different. So this really hit hard when I opened my own practice, because we're a cash pay practice. And so patients are they start asking you those questions, how much does this cost? And at that point, you really have to understand where you're sending them, what might be covered, what's not. CBC is a complete blood count. It's kind of the most basic blood test that we order on every patient every day, all the time. So very common thing that they should have known or been able to answer for me. So as you become a direct care physician, this becomes a huge part of the conversation and advising and advocating for patients instead of just, good luck, here's what I want you to go get.
Yeah, and I think it's important to note that patients who become part of direct care model, some of them have insurance, some of them don't have insurance, but both types of patients actually benefit from knowing what is the cost of something, because that way they can actually shop around and do what's best for them and their family. So, Christine, you have spent years reviewing medical bills and challenging hospital changes. What are some of the most common billing errors or inflated costs or questionable practices that you've seen?
Um, there's a lot of unbundling, taking one code and breaking it out to several codes to increase the reimbursement. One of the biggest things is now the facility fees. Every time a hospital buys a doctor's office and you go to visit that doctor where you used to pay $150, $200 maybe, now the facility, because they own the building, has added between $400 and $900 just for you to walk in that building that they own.
Mhm.
That's the biggest thing. And the charge masters, they have a gross charge, a minimum charge, and discounted charge, cash charge. The gross charge is inflated so much that when you get a PPO discount, it looks like you're paying half of what they normally charge, but actually you're paying 10 to 15 times what Medicare pays because they've inflated it so much.
Yeah, that's crazy. And a lot of time patients, when they get the bill from the hospital, they really don't know how to read it. So I usually tell them, ask for the itemized bills because I've seen it in the past where they could charge $800 for ibuprofen.
They will, but when you ask for an itemized bill, and I've learned this the hard way over the last few years, always get your medical records first and then get the bill once you have the medical records in your hand. Because when you request an itemized bill, the hospital senses there's a dispute coming. They
Oh,
will look
okay.
at it and they will. I've seen it. I've actually had it happen. They changed the medical records, not knowing that I already had a copy. So you want to get the medical records first and then get the itemized bill and then try to compare that to your EOB.
Wow, that's interesting. I never knew that actually. So, this question goes for both of you, and you can decide who'll go first. But has healthcare become more expensive partly because the patient receiving the care is rarely the person that's actually directly negotiating or paying for it?
Absolutely. Everybody that stands between a patient and their care is making money. The broker that sold the policy, some TPAs, not mine, but some TPAs will charge a percentage of savings off of the discount they get. The PBMs have the spread, and we typically pay cash for our members, direct primary care, direct pay imaging, independent labs. Anywhere we can buy the care outside of the insurance system, that's what we do. An MRI, one of our clients just had $5,000 that the hospital wanted to pay up front. It was $375, 15 minutes
Wow,
away.
it's totally crazy. $5,000 versus $375. In my area, it's like $425 for MRI, but you can shop around. Sometimes you'll find even discounts because some radiology places will run, monthly discounts or something like that. I think it's
Right.
really important for patients to kind of know what to do because $5,000 is just insanity.
Well, and there's a hospital in Las Vegas. The Las Vegas State Employee Benefit Plan is in danger of being insolvent by 2028. So I went
Wow.
looking, and the broker showed a graph that showed a 62% discount off of the claims. So I pulled up one of their hospitals, that same CT scan. The hospital had it listed for $21,000. The
Wow.
negotiated discount was $7,700. So it looks like they're getting a 62% discount. That's what the broker is showing, 62% discount. And it sounds great, but you're paying 20 times what it should cost
Yeah, I was gonna say,
on the
except
free
it's supposed
market.
to be, yeah, it's supposed to be like what, 250, 275, maybe
But
if
it
you're
looks
doing
great
like
on
the IV.
paper.
Yeah, on paper it looks amazing. Wow, that's crazy. What about you, Molly?
Yeah, I mean, Christine makes a good point that everybody from the insurance side is making money at every step, but look inside the hospital at who's making money. This really changed with Obamacare, and people find it very distasteful to talk about physician income, but I think it's part of the conversation we need to have because as we go into a physician shortage, we need to know that for the last 20 years, doctors have taken a pay cut. So you may get a raise every year for inflation. Doctors are actually taking a cut, but guess who's not? Are all the middlemen and the healthcare administrators and the CEOs that are taking 7 and 8 figure bonuses. So when you go support the system, those inflated costs, that are making individuals go bankrupt are actually paying for all the layers of administration. They're not actually paying for the nurse and the doctor taking care of you and the people who are in touch with you. So when you know that and you understand where your money is going, it's really infuriating, especially if you're a doctor who's been in the system and been treated, as an employee by these people disrespectfully and treated like a widget. So I think a reckoning is coming. I want to share one example of a friend of mine. It's a patient who has come through cancer, and what's happening in some parts of the country is there's a monopoly that's developing. So, for example, a university is buying up all of the cancer centers, so they're all coming under the monopoly. So, what used to be, and then Christine alluded to this, what used to be a $50 copay to go check in with the oncologist is now an $1,800 visit that the doctor doesn't know the career of the person, doesn't have really any suggestions. It's a 10-minute visit and it's $10 worth of labs for $1,800. So what's happening is this will bite patients one time. And then the second time it's coming up, they're going to ask themselves, did I get $1,800 worth of value out of that thing? Because I'm not going to keep going there. So what are my other options? And I think that's where this discussion is going tonight, or what are your other options once you're in that position?
Mm-hmm. But let's kind of backtrack a little, Christine, and have you explain to us some of the basics. What is a self-funded employer health plan, and how is it different from traditionally fully insured plans?
Well, fully insured plan, the company pays the premium and the insurance company assumes all the risk. Self-funded, the company pays some of the claims. They do by stop loss, so they only pay up to a certain amount per employee. And then the stop loss will kick in and cover everything else. But with self-funded, you can design your own plan documents. Like when we design a plan document, we waive cost sharing for independent doctors, independent imaging, independent labs. Patient pays nothing. So we remove the friction between the patient and the care. And that prevents them from not being able to afford a $150 doctor's visit, or in the case of going to a hospital-owned doctor, $1,000 for an office visit. They won't go because they don't have the money. They get sicker. They come to work. They bring what they've got to other people at the job. And then you've got a whole massive bunch of office people or manufacturers that are out of work because they're sick. And then they wind up in the emergency room, and there's where the high dollar claims are. So by removing the friction to the first line of care, the physicians and that imaging and the labs, you prevent so many hospital stays that the claims costs just automatically go down.
So you warned that employers may have fiduciary responsibility to oversee the spending, the healthcare spending. What does that responsibility mean for business owners, the CEOs, CFOs? Because you're seeing a lot of business owners, have these self-funded plans and things like that. What is their responsibility?
They are actually the fiduciary of the plan. And with the CAA of 2026, when they removed the gag clauses, used to a CEO could say, I don't have access to my claims. Mm-hmm. And that's not an excuse anymore. They have access now because of the removal of the gag clauses. So they have to be reviewing the claims. They're not as responsible for the total cost of the plan, but they have to be able to prove how they determined what the cost should be. Did they look at different PPOs? And CEOs, a lot of them don't know that they're the fiduciary, number one, but they don't know that when a broker says, we got you a 67% discount, what's that a discount off of? And they should be asking, what's the price, and how does that price compare to what Medicare reimburses? Of course, the hospitals aren't going to accept Medicare rates from a company, but they will accept 140, 150% most of the time.
So what is the reference-based pricing, and how can a health plan operate without relying on a traditional PPO network and its confidential rates?
Reference-based pricing is we get the claims in instead of using the network discount, because we simply don't use networks. We price that claim at 140% of Medicare and process it that way instead of those discounts.
Mm-hmm. So what questions should employer ask the insurers, brokers, and third-party administrators?
For insurers, they need to ask what the network fee is to access the network. And this is on self-funded. If you have a Blue Cross Blue Shield logo, that doesn't mean you're fully insured. That means you could be self-funded and you're just leasing that network. You need to know what the fees are. How much is the commission? Is the broker getting any kickbacks from the PPO fees or any other ancillary product? For the TPAs, one of the main things to ask is, are you getting anything from the person that you outsource to negotiate out of network or large claims? Because a lot of people will charge 20, 30% of savings. So if somebody sends me a claim with $100,000 in savings, then they would write me a check for $30,000. I don't do things that way. I don't charge my clients for that service, but that's where there's a lot of money floating in the background with those percentage of savings. Anything that says percentage of savings, 3 or 4 people have money go into their pocket.
Yeah, and I think, just learning this whole healthcare insurance landscape, it's not surprising that more and more physicians and patients are trying to really just skip the middleman and go directly to the source, whether it's direct primary care, concierge medicine, or different models that we have out there. So, Mollie, you were a hospital physician, so you had to rely very heavily on the kind of traditional model. COVID happened, you had your own experiences and kind of decided to leave the system to go to direct care, just you and the patient. So, how has that changed for you? What experience have you had so far, and why have you done it?
Yeah. So I did it because the first time I went out and had my own practice, I actually went bankrupt. And I found that out in a hit piece someone wrote about me while I was on stage, similar to this. It was interesting. I was reading and scrolling and trying to find out what was happening. So my first practice went bankrupt. I didn't have a business plan and didn't know what I was doing. I didn't have a lot of lead time knowing I was going to be running my own practice. And the insurance didn't pay me for about 2 years. Like I was seeing patients every day and that payment never came. So I had to, I went back in the system. That was 2020. When a little before that is when that happened. So when 2021 came around and I left the ICU, we did it different, right? That was my education, the first practice. So it was all direct pay. And the concierge plan, I like to know who's on my merry-go-round. Like, who am I taking care of? Because to me, it's not one-way communication. It's not patients just call me when they need me. Like, I'm going to call them and check on them. Like, hey, I found something that applies to you, or this might help you. So I want to know who wants to be in communication with me on that. So I do have some advantages because the people who find me want my care. They're a little bit more informed, right? I don't have to take all comers like the ER does. So it does select for a better population, but I think the people who show up are more invested in their health. They're more proactive. They're more price sensitive. So it's been wonderful doing that, and because of that, we've actually been able to take, somebody's investment at the hospital that would have been like one admission or one ER visit. We put that toward treatments that actually help people, and we can change lives.
Definitely. So this question, actually, it was in the chat, so I'm probably going to reward it a little bit. But what kinds of healthcare can patient or employers realistically purchase directly? So we know that there's, direct primary care type of a relationship or concierge when it comes to the patient physician. But what about laboratory testing, imaging, medication, specialists, and outpatient procedures? And the specific question in the chat was, are there any websites where people can actually inform themselves about these specifics? Either one of you.
There's some
I know my
information.
answer, but what do you guys think?
Well, as a consultant advisor to employers, I try to find every cash pay facility or practice that they can access. Direct primary care, concierge, labs on demand are pretty much all over the country. There's imaging centers pretty much all over the country. All that you can pay cash for. You can set up direct contracts so they just bill the company once a month. More specialists are coming on the scene now that are direct pay and transparent. Surgery centers. I just had one a few weeks ago that we offered to fly from Pennsylvania to Oklahoma would have saved $55,000 on the
Wow.
surgery. So it's coming, and it's got to get better legs under it, because that's truly the only way to affect real savings on a health plan. That and RBP, and not and just getting rid of the networks. Get rid of the networks. Get rid of the brokers. Brokers hate me for saying that, but my personal opinion is that the base word of broker is broke for a reason.
Yeah, and actually, Dr. Keith Smith is one of the leaders of Molly, help me. I think it's like FMMA organization or something.
Yeah.
But he is founder of the Surgical Center of Oklahoma, and I remember going to one of the meetings that they had, and at the time they were doing ER in Oklahoma. Him and someone, he was helping this ER group set up ER, and the way they were billing was based on level of care, kind of bundling up prices to make it affordable for patients who wanted to price around and not necessarily, rely on their insurance and all the things like that. So there's a lot of innovation out there. And I would say from my perspective, I always tell my patients, shop around, look around, and call and find out who has the best price, and, just do it. The same thing with medications. What about you, Molly?
Yeah, I think the Surgery Center of Oklahoma has absolutely been innovative in how I don't know how they can do it as a surgeon, like how they handle complications and things. I really want to understand that. But what we need buyers to understand how to buy healthcare, and we need doctors to provide that care in that setting. So I've been talking to a lot of doctors because I'm getting in the fight on this. I met Christine, and it kind of put a little gasoline on my fire in a different direction. Where it was going already. But doctors can't understand how this is going to work, right? Because we've kind of been brainwashed, we've trained in the system. The system is the assumed path everyone is going to take. And moving with employers is going to make the fastest change happen, because they're going to save money. Patients are going to save money. You're going to support practices that are out there doing the right things for patients. Like, that can happen over a 1 to 5 year period, versus if we wait for individuals to figure it out, we're looking at 20 years. So we are really teamed up, and I think this aligns with IMA's goals very nicely, to help employers find those solutions for their people. It helps everybody downstream. Everybody wins except the system that's like literally exploiting patients
Every day.
every day. So you've got people, Keith Smith at Surgery Center of Oklahoma is the FMMA, Free Market Medical Association.
There you go.
Yeah,
Yes.
they connect buyers with sellers. Their director, Matt Ort, made some of these changes, was really groundbreaking in Wisconsin to convert this over. We have Noah Kaufman creating the direct acute care model, where he's got urgent cares in, I believe it's Denver, Colorado.
Denver, yeah.
So what we need to do is we need to all unite so that we know where to send people. That's a great question. Where do we go online to find that out? I really don't think there's one unifying source. IMA has the Trusted Referral Network, or Trusted Physician Network. So they've got to start on it. You have AAPS that's got to start on it. MedMaps has to start on it. You really just, if you can plug in with one person that's in the system, they're going to help you find their people. And that's how we're going to grow this.
Yeah, and I think for patients, also one of the important aspects of this free market revolution, for lack of the better word, is the health savings account. A lot of people are getting these health savings account or flexible spending accounts through their employers. Christine, how can they use them more strategically? Because a lot of people actually will put money in there, or they don't even know that they have money in there, or they don't know how much money they have in there. And then, they kind of, it just sits there. And in the meantime, it could be really an asset for them.
Right. Well, the HSAs, it's a 3-tier tax savings. It's tax-free when they put it there. It's tax-free if they pull it out for medical expenses, and then it's taxed as regular income. It rolls over until you're 65. As of 2026, you can actually pay your direct primary care up to $150 a month out of that HSA account. FSA is a little different because it's a use it or lose it. So at the end of the year, if you haven't used what's in your account, whether you put it there or your employer put it there, you lose it. The HSA is a much better way to go if you it has to be tied right now to a high deductible or a bronze plan. So you can't have a premium plan and an HSA, which doesn't make any sense to me, but that's the law as it is right now. But if you have that high deductible, then you can pay your deductible, you can pay your co-insurance, your co-pays, your prescriptions, anything medically related, you can pull out of that HSA tax-free and pay it.
Yeah. So, I know that there's definitely a better, I would say, experience that patients have with the direct primary care, which is suggesting, patient satisfaction, decreased use of emergency room, even decrease in chronic health issues because of the continuity of care. I know the health sharing plans who love when their patient says they have a direct primary care doctor because they know they're going to have their money saved. But how does this affect employers? I have a very good friend in Florida who is excellent and has many actually contracts with employers directly because they see value in what he has to offer to them. And one of the hospitals, all of their employers are part of his practice. So, Christine, are you seeing a shift in this where the employers are going to direct primary care type practices to actually get the benefits?
If they're getting the right advice, they are. And I'm not a clinician, but a lot of times a doctor will come to me and say, how can I contract with a local employer? So I run the numbers for them. And basically all I do is pull the facility fees from the hospital charge master and say, show them this. This is how much extra they're paying every time somebody sees a doctor that's employed by that hospital or owned by that hospital. And the employer will reach out and say, can we direct contract with you? Because they'd rather pay that physician independently $250 than pay $250 at the hospital and then a $400 to $800 to $1,200 facility fee. It's just plain common sense. And I've had people say, well, my TPA waives cost sharing for independents. If they go to an independent doctor, imaging lab, they don't pay any copay, any deductible, any co-insurance. And a lot of people say that's just throwing money away because the employee should be on the hook for some of that. And there's two ways of looking at it. Depending on the industry, I work with a lot of manufacturers. Those people can't necessarily afford a $50 copay or a $100 copay. So if they don't go to the doctor, they wind up at the emergency room. If they don't go to the doctor, they wind up in the hospital. So spending a little on the front end way outweighs the risk of them going into and creating those high dollar claims. Now, employers don't have to do that. I recommend it because it's just removing the friction.
This is really why I wanted to cover this topic. I want to go back and highlight something she said because people tell me all the time, I can't afford your kind of care. How do I do this? How do I do it with my insurance? She is saying people under this plan. So if your employer can go to a plan like this, you're going to have zero out of pocket for your DPC. You're going to have zero out of pocket for your labs, for your x-rays, if you use the preferred sources. So if you are an employee, I would go to your employer and say, hey, have you looked at this? So that these are your action points for tonight, right? You don't want to just sit here and listen to us. You want, what can I do about it? Go to your employer and ask if they've looked into this. And if not, have them find somebody to help them.
Exactly.
You can get this kind of care with zero out of pocket.
So, Mollie, this question is to you because this is really, I would say, the big deal about this whole conversation we had so far. There is definitely a demand for direct care. At least I see it in my area. We see it online. People are asking, how do I, find the doctors that actually do this or the ones that align with, my beliefs, my values, and things like that. So as this demand keeps on growing, will we actually have enough independent doctors to meet it? And I kind of know the answer to that, at least my own answer. But what will actually take to encourage more of our colleagues to step outside of the system? Because we have been chained by the system. We have been spoon-fed the system. And I know when I decided to go into this, I had a friend that was telling me for years, you have to do it, you have to do it. And I was like, nah, I'm good. I don't want to. I don't want to be my own boss. I don't want to do, this whole thing. I don't want to have the overhead. I don't want to worry. I just want to go home. How do we actually encourage our colleagues to step out?
I'm glad you asked. So I just want to go back to the DPC data because over 7,000 employers now offer DPC benefits, and this is just getting going. So I do think this is a huge sector of the population. Here's my big concern right now is if COVID happened again tomorrow, we would be in the same boat we've been in because the problem was not that there weren't good treatments. The problem was 95% of doctors were plugged into a system that threatened their job if they didn't do what was posted on a piece of paper and get their shots. So we need more independent doctors. But just to your point, Kat, not a lot of them feel confident running a business. They wonder, will it work? How do I get patients? How do I do all of this? So one of the things I've been working on to help meet that need is Maverick Medical Ventures. So we are going to be the business side of helping independent doctors get set up. This is the most common question I get is where can I find a doctor like you? And the answer is there's really good doctors out there, but they either have student loans, they have families, they have kids in college. They need to have an income. And if you're 200,000 plus in debt and you want to go start a new business, guess what? There's zero banks out there that want to fund you. So getting startup funds for this is almost impossible. So through Maverick Medical Ventures, we will be the premier business support for independent physicians. And that is through helping them with marketing, understanding the financial side of it, and understanding operations. I know Katie's on here. She's my operation guru. She's run practices of all sizes. This is what most doctors miss and don't understand is how to operate the practice efficiently and cost effectively, which directly benefits the doctor and the patient, right? So Maverick Medical Ventures is the name, and our goal is to help create those practices and fill them with patients, that Christine's employers are going to be looking for.
Yeah, and for those people who are afraid to do it, I can tell you I did my own practice with $5,000. My medical school bag. I had my otoscope that I bought when I started medical school, my stethoscope, my ophthalmoscope, and my blood pressure cuff. That was it. And I started it. And, having someone like you to actually navigate how to do it, it's really important because you're right. The scariest thing for me was the day one, I had no patient scheduled. And the question for me was, how will I get them to actually come and see me? Luckily, I live in a small town and everyone knew me, so it wasn't too difficult. But it can be done. It's a huge leap.
Yeah.
It's a leap of faith. But I would say that I've never been happier, and I know you're happy doing what you're doing. And Christine, I'm sure her employers and people that she works with are happier when they actually have a good relationship with their providers.
With their providers, absolutely. It's the continuity of care.
Yeah, exactly. Okay, so I think, ladies, we had a great conversation. I'll leave it at this and we'll bring Autumn to start asking a few questions because I saw some of the questions in the chat. So Autumn, please join us.
Hello, ladies. Before we go in, if we could pull up, Livio, that link for Maverick Medical Ventures again, just so our audience can know where to go to find it. See if we can have him
do
pull
like
it up.
a 2-second pitch. We have our inaugural live event coming up October 15th through the 18th. That is get in a room with other people building. This is going to be the place where you start to build that network. I see a question. Will we help you find people? Yes, we have to get them there and network with them. So we will. And we just found out we're going to be awarding CME for that. So if you're a doctor sitting out there, this will be a CMA eligible event. So come learn how to manage a practice and let us help you with the hard business side. So thank you for sharing that.
Yeah, no, absolutely. I'm going to try to go through. We have a lot of questions, so I'm just going to go through as many as we can. Sophie asked, is there any way that the direct primary care or direct specialty care model can work across states? I live in the New York area, and when you are self-pay at offices that are outside the system in this region, it is still outrageously expensive.
You're in New York. I don't know what else to tell you.
I was going to say New York is a hard one. I have a lot of friends who are in New York and they keep on begging me to be their doctor, but it's very difficult. Even there are a couple good physicians in New York who do this. We have one of our doctors who has helped with starting FLCCC who's there. So I think it would be the most important thing is to find someone in New York and look maybe on our network to see if it's someone there. But for us who are doing this, like I have licenses in different states, but New York is a difficult one to get the license unless you actually live there. So it's a difficult state.
And there's some practices where if you travel in to the location, you can establish care, and then there might be an opportunity to follow virtually. I don't know the laws in New York, but that may be an option as well. So
Before we stray too far away from the Maverick Medical, we just had an anonymous attendee ask, is Maverick Medical interested in helping nurse practitioners or doctors only?
we are, nurse practitioners have unique needs. So the program right now, we're just launching. So we are focused on physicians. If you're a nurse practitioner, follow along with us, reach out to us, let's have a conversation. We want independent practices. So the needs of nurse practitioners are slightly different, but we'll work through that with you. So
Ogla asked, is there an example anywhere in the world and in the history of the medical model that it works well?
I think your DPC data that's coming out of the United States actually shows the closest thing to what I would consider the old school medicine. You know, fewer ER visits, doctors are happier. And if your doctors are happy, you're going to get better care. Patients are happier. You've got trust. You know, you don't need to come in for a 30-minute visit or an ER visit if you have a UTI, if you know your doctor and you trust each other. So building that relationship is the most important thing.
And for the employers, and Christine can back me up on this, what they see is that their members are not overutilizing hospital, they're not overutilizing ER, they are not overutilizing radiology centers and things like that. So there is saving on the employer side. So a lot of employers actually will say, okay, this is working out, and then they'll speak to their colleagues. You know, they have other small businesses and say, you should look into it. And please, Christine, you can talk more about that.
Well, that's exactly right. And I've talked about waiving cost sharing. Not every employer is going to do that, but they can incent the people to with a copay or with a lower percentage or a lower deductible to go to these cash pay prices and places. But more and more, I mean, every day I'm looking for new independent practices. I just found 2 new ones that popped up in Pennsylvania, and I've never been happier in the last 6 months than I was to find these 2 new direct pay practices. But it's truly the only way to affect healthcare savings based on our current industry. When a PPO discount shows 62%, but it's 62% off of a rate that's been inflated 20,000%. So you're actually you still wind up paying 20 times Medicare. That's not a discount. So when you talk to a broker, an employer talks to a broker or a TPA or whomever is putting that plan with them, don't ask, what is my discount? Blue Cross, Cigna, Aetna, United, they're all going to say, we have the best discounts. Well, you don't know that because their discount at one hospital for a CT scan is going to be different than at another hospital for the same scan. The price is never the same. The gross charge is never the same. The PPO discount is never the same. But when you base your rates on Medicare, be it 140, 150, 180, you know going in, you set the prices instead of setting the discount.
Another question that came in from Bob Isaacson was, do you see any efforts on the part of insurance companies to help establish nonprofit hospitals and healthcare clinics as a way to reduce costs? Do you know of any models of success that can be used as case studies for others to follow?
Can I answer that one?
Please.
I'll go second.
There is no such thing as a nonprofit hospital.
That's what I was going to say.
Nonprofit hospitals are by far the least charitable hospitals that you'll find anywhere out there. HCA is a for-profit hospital. If you don't have insurance, you automatically get a 92% discount. A nonprofit hospital will pay its executives 8-figure salaries. And there's a lot of executives that they pay to 8-figure salaries. They send people to collections. They do not screen them for charity care before they send them to collections. I had one a couple of weeks ago threaten to withhold a heart surgery because of a disagreement in payment amount. So when you see nonprofit, that's give me the word, Molly.
Fraud.
Yeah, kind of. Yeah, I
Fraud.
mean, there's no such thing as a nonprofit hospital.
I want to give a shout out to Dutch Rojas here. If you follow him on Twitter, he breaks this down very clearly
He does.
about nonprofit hospitals and what they're doing. You know, they're putting their name on stadiums while people are going bankrupt. And I want to throw out one statistic that I thought was fascinating because I think most healthcare decisions are generated on fear. And most people buy insurance because they think that it's going to protect them financially. 65% of people who go medically bankrupt have healthcare insurance. So it is not doing the work that you think it's going to do. And I think more and more people are getting really ticked off that they're paying these huge premiums. Then when it's time that they have a medical need and it doesn't pay. We need a prior auth. You can't get the MRI. You can't get the PET scan. You can't get the chemotherapy. Why did I pay all this money if now when I need it the most, I can't use it? So this is about to hit a fever pitch that people just give up, and the complexity and the fraud and the corruption built into it is going to be too much.
It is too much.
Laura asked Molly if you could spell out Dutch
I
Rojas'
did.
name. Oh, you did?
I did.
Thank you, Dr. Lindley. Another question that we got from Ellen O is, do you know much about the supply chain? Helium shortages are shortages are affecting MRI access and cost, especially for lower cost MRI places like radiology assistant or places that accept Medicaid. Thanks for your work on this important topic.
I believe the helium cools the MRI magnets or something like that. I do remember reading something like that. I'm not an expert on that. Supply chain affects everybody. So if you have less margin, you're going to be affected more.
Do either of you have any other additional thoughts on that question? It's a little bit of a
I
long
don't know
one.
anything about the provider side of the supply
So
chain.
yeah, it kind of depends, right? We're actually dependent on many ingredients to our medication being produced in China or India. And, with everything that's going on in the world economy and different things, a lot of times you have these issues with supply chain shortages. I know during a pandemic or like towards the end of it, we had issues, and Molly, you'll remember this. Remember the IV fluid bags? They couldn't get enough IV fluid bags, and people had to figure out how to just give the fluids, and they had to ration their own things. So it's always been an issue. It's always going to be an issue. We really, when it comes to our own healthcare, we need to make sure that we start producing many of these things back at home, so we're not dependent on the political or economical stage.
Absolutely.
Yes. Yeah, it happened to, you might have said this, but it happened to the North Carolina hurricane.
Yep,
So-
that's I remember that. Asheville, I think they had a big storage area there. Yeah, they were
Baxter,
affected.
yeah, the Baxter plant was there and it got taken out by the hurricane. So
Yeah.
I think if the general public knew the drug shortages that were dealt with behind the scenes every day, they'd be terrified. It's a constant, churn in the hospital, and they always seem to make things work because there's enough alternatives. But I agree, if there's somebody out there listening that's a manufacturer, investor, get them going here in the country. Probably the FDA is the big holdup on that. So.
Another question came in from Melanie Top. She said, I am self-employed and use the exchange to purchase a high deductible plan in order to fund my HSA every year. I never use the insurance because it's horrible care. I pay cash for everything. I'm considering dropping my insurance altogether, but this makes me nervous. Does anyone know of another way for people who are self-employed? I hate paying for what I never use, but I want to max the retirement account and take advantage of the triple tax benefit.
There's two ways of looking at that. I mean, the HSA is a triple tax benefit, but if you have to spend $12,000 on a plan to be able to have that HSA, then you really haven't saved anything. You keep your money in your pocket. I use a health share. I don't use traditional insurance. and a couple of the health share with my DPC, and I'm covered. More so than if I had a Blue Cross Blue Shield, because I don't have to get a prior authorization to get an MRI. If I want an MRI, I go get it. Same thing with a CT scan, a prescription drug. I just get it. And if I go over the shareable amount, then I get reimbursed at 100% over that amount. But, it does, what's the $4,500 maximum, $4,400 for the HSA contribution? Well, you save 28% on taxes if you're in the right tax bracket. So that's, roughly $1,000 you may save on taxes. But if you're spending $12,000 to be able to have the HSA to start with, then you've lost $11,000. Does that make sense?
Melanie asked, what's a DPC that you just referenced?
And we answered it in the chat, direct primary care, and also asking about health share. What is the health share? So Christine, if you can give them a little background on health share and what their options are, I think that'd be great, because many of my patients actually do exactly that. Health sharing ministry, DPC, they save money and it makes a lot of sense for them.
Well, health share, they can't call themselves insurance because the government says they can't. They operate kind of on the same. Instead of having a deductible, you'll have an initial unshareable amount, and you get to choose that amount. I'm 59. I pay $207 a month. I have a $3,000 initial unshareable amount. You still pay your doctor's office visits, the smaller stuff. The health share is for something catastrophic. But then you couple that with the direct primary care, and that's where you get your office visits, your labs, basic x-rays, sutures if you need them. My DPC kept me out of the emergency room a few years ago by putting 4 stitches in my finger at 8:30 on a Saturday night. It would have cost me $5,000 next door at the hospital. So there are a lot of health shares out there. Just investigate every one. You can search health shares, and I think there's health share ratings. I use Zion. I have absolutely no affiliation. I get no commission off of it. It's just the one that I found that fits me the best. They do exclude pre-existing conditions for 12 to 24 months, and then it's graduated in. They exclude some coverages that ACA says you can't exclude, but other than that, to me, it's a better option than insurance for self-employed, because you don't have that deny, delay, deflect.
Well, I think the other
And
thing that's critical
go ahead,
too
Molly.
is if you don't have a health insurance plan, you need to put that premium in a savings account. I think that's the biggest problem is people just think they got to raise. You've got to put money back for a rainy day because something's going to happen. And you might be able to directly negotiate that. You may want to be in a health share, whatever that looks like, but you've got to save the money because you're going to have healthcare expenses.
And I just wanted to echo Christine. I had Zion Health Share, again, no affiliation whatsoever. And for 1 year, they did not cover my prior existing. Essentially, they didn't pay for the medication, but it was cheap one anyway. And after that, everything was covered. It wasn't an issue. And we had really good experience with them. And
they reimburse for some preventive medicine.
Yep, they actually do. And that's an important point because not all of them do. So it's really, that's an important point. You can do all your preventive visits and they'll reimburse you for it.
Well, and if you look at the expensive stuff outside of a hospital, that's your biologics. That's your biologics, your immunotherapies, things like that. I don't use a lot of those. So, I mean, I know some people need them, but there's a lot of things you can do before you get to medicines that are $10, $20, $40,000 a month to try to treat your condition. So it's just a matter of where do you draw that line? How much protection do you want? We can find cheap generics. We can heal the gut. We can do other things that are going to help the condition indirectly in many cases, not all of them.
Another interesting question that came in are any of your thoughts on the role of AI doing diagnosis and et cetera?
Molly, that's more your
AI.
I'm looking forward to AI for these hospitals to be using AI to code claims, because AI absolutely cannot audit a claim. So the more they let AI code it, the more mistakes I'm going to find, and the more I get to cut from the hospital's payments. It's just as simple as that.
AI to me is terrifying. I think we need to talk about real intelligence, and I think there's a lot of that missing in medicine right now. But AI can help you if you're on the right path, right? We have more and more patients coming in that have run their labs and their x-rays through AI. And it's great to give you ideas, but it misses context. And if you don't put in the right prompts, you're going to get the wrong information out of it.
Right. You've got to know what questions to ask
Yeah.
for you
Yep.
to know what questions to answer. And if you don't formulate those questions correctly, you're going to get bad information.
And I always say it's only as good as the person that wrote the program.
Exactly.
And their biases too, because they all have biases.
Very much
That's the
so.
problem. Yeah.
Very much so. And one thing, because I know a lot of people are on this call, that I see over and over and over again that costs people thousands every year, is your annual wellness visit. Whether you go to a hospital-owned doctor or an independent doctor, you should always go to an independent doctor. The doctors don't know what ACA requires to be covered for wellness labs. Most doctors will order CBC, lipid panel, metabolic panel, vitamin D, A1C, Mollie, TSH. The only lab that ACA requires to be covered at 100% under the wellness benefit is the lipid panel, because there's a drug attached to it if your cholesterol's over 180. So what happens is they go to the doctor, they get the lab order, they go to the lab, be it independent or the hospital lab. Only the lipid panel gets applied to their wellness benefit, and then all those other tests get applied to their deductible. 2 months later, they get a bill for $1,800 for what they thought was going to be covered at 100%. So you always need, before you go get any wellness labs that you think are going to be paid at 100%, you need to call and make sure which ones are actually covered as wellness, because most insurance companies only cover that lipid panel.
Different discussion, but a lipid panel is $9 and it's the wrong test. An advanced lipid panel is $40. Those bill at several $100.
Independently, at the hospital, it's $192.
Yeah, correct. Yes.
Crazy.
Mm-hmm.
Well, before we move over to our closing announcements, Christine or Dr. James, is there any final thoughts that you'd like to leave our audience with?
All I can say is support independent practices, imaging physicians. Anything you can find that is not associated with a hospital and that will keep you away from a hospital is going to lower your healthcare costs astronomically without much effort.
I would say don't act on fear. We've acted on fear and made decisions in healthcare on fear for decades. And it's so confusing and it's so overwhelming. Most people just forget it. Sticking with IMA, learn the basics, learn how to navigate. 80 to 90% of what you need is not that intimidating. So take ownership of your own.
And most of the vendors in the space, the brokers, the carriers, they want you to think it's complex, and it's really not. Once you peel the layers back and you get rid of all these third-party vendors, I want to put myself out of a job. I want every employer to know how to buy independent care, how to pay for it, how not to pay a broker $1 million a year, and bring everything that they can in-house. But until that happens, everybody that walks in their door is telling them how complex it is, how they're not going to understand it, how they need to do it for them. And then they start selling all these ancillary products and indemnity plans, and it's really not that hard once you break it down.
Well, thank you so much, Christine and Dr. James, for joining us for this discussion tonight. It's been extremely informative, and I wish we could get through all of the questions. But I know Dr. Lindley wanted to say a few words on the loss of Annalise Camp. Dr. Lindley, I'll pass it to you. But thank you so much, Christine, and thank you, Dr. James, for joining us.
I've enjoyed it.
Thank you, ladies. So many of you may know the story of Annalise Camp. In June, she was at a family event, and she incidentally fell into the pool and was taken to the hospital, Texas Children's Hospital at the time. And there was a controversy because the hospital, after a certain period of time, tried to pursue a brain death determination for Annalise. Parents objected. They wanted to have alternative treatments and supportive care because they wanted to try. In the state of Texas, we have something called right to try law. When all this was happening, there was a lot of outrage, a lot of different calls of action on X, and IMA joined others in calling the Texas Children's Hospital to allow for the family to pursue every venue to try to see if they can help with Annalise's care. This lasted for several days and weeks, and I know the Attorney General Paxton's office got involved as well. Annalise was transferred to a different hospital where they tried everything. Our own physician and leader of IMA has tried to help with Annalise's care, but with great sadness, we mourn the loss of Annalise Camp, a 2-year-old child who passed away. And I think this highlighted the need for states to actually look into passing legislation, Parents' Bill of Rights, because despite having this right to try law in Texas, this family had to really go through different obstacles in trying to get care for Annalise. So IMA, our colleagues, our staff joins everyone in mourning the loss of Annalise, but we know that her death has really highlighted a need around the United States and in my own state of Texas. And we will continue the fight for children and for others who have been declared brain dead, because their families should be allowed to pursue every venue to try to bring them back. So that's really it.
Absolutely horrible. Thank you, Dr. Lindley, for giving everyone that background and that update. And on that sad note, I will move on to our closing announcements. Okay, so next week, we hope that you'll join Dr. Joseph Verone and Dr. Ryan Cole for an episode titled From the Asia Pacific Symposium, A Global Vision for Patient-Centered Care. They will be sharing highlights from conversations with physicians from this symposium and discuss the challenges facing healthcare and the importance of the patient-physician relationship and how we can build a more independent, responsive, patient-centered future for medicine. That's next Wednesday, August 12th at 7 p.m. Eastern. If you're interested in the future of medicine, we encourage you to read the latest article from Dr. Joseph Verone, our President and Chief Medical Officer. He explains why AI and telemedicine can strengthen healthcare, but should never replace the human connection between doctors and patients. You can read it now at the link on screen or by visiting our website, imahealth.org. All right, well, thank you all so much for joining us tonight. But before we close, we wanted to highlight IMA's series, Medicine at 250 Years. Each week, we share new videos and articles featuring IMA senior fellows as they reflect on the past 250 years in medicine. Their different backgrounds and medical specialties offer unique perspectives on what medicine has gained, what it has lost, and what should come next. You can explore the full series at imahealth.org/medicine at 250 years. To close tonight's show, we're sharing one of the videos from this series titled Ancient Wisdom, Modern Healing, and the Whole Person, featuring IMA Senior Fellow Dr. Adil Verone. Thank you all so much for joining us tonight, and let's take a look.
Hello, I'm Dr. Adil Verone. I'm a doctor of traditional Chinese medicine and a licensed acupuncturist in the state of Texas, a senior fellow at the Independent Medical Alliance, and also the assistant editor-in-chief to the Journal of Independent Medicine. When we talk about returning to the roots of medicine, we're not talking about going backward. We're talking about remembering something we've forgotten. Long before hospitals, insurance companies, and electronic medical records, healing existed. Every culture developed ways of understanding the human body by observing nature, generations of experience, and the relationship between the mind, body, and environment. They recognized that digestion affected energy, that stress influenced physical health, that sleep mattered, that emotions could manifest illness, and that lifestyle often determined whether someone became sick in the first place. In many ways, the ideas aren't revolutionary, they're timeless. As American medicine evolved, especially through the early 20th century, there was an important push towards standardization. Medical education became more rigorous. Licensing helped protect patients from dangerous practices, and scientific advances transformed medicine in remarkable ways. We should celebrate those achievements. But somewhere along the way, our definition of healing became narrower. Community healers, herbal traditions, midwives, and centuries of practical medical knowledge were often dismissed rather than studied. Some practices certainly deserved scrutiny, but others offered valuable insights into prevention, resilience, and caring for the whole person. Insights that we're now beginning to rediscover. As a doctor of traditional Chinese medicine, that's the lens I bring into healthcare every day. Traditional Chinese medicine doesn't ask what's the disease. It also asks what is in this person's body and how has it lost its ability to adapt. We look for patterns rather than isolated symptoms. We considered sleep, digestion, stress, pain, emotional health, circulation, nutrition, movement, and recovery as parts of the same conversation. The goal isn't simply to remove symptoms, it's to restore balance so the whole body can function the way it was designed to. Acupuncture is one tool within that system. And today we have a growing body of research supporting that role in pain management, stress regulation, sleep, nausea, recovery, and many other chronic conditions. But beyond any single treatment, traditional Chinese medicine reminds us that health is a dynamic. It's something we cultivate, not something we simply react to after a disease disappears. And importantly, it isn't about choosing between conventional medicine and integrative medicine. It's about recognizing that they're each a different answer to a different question. Modern medicine excels at emergency care, surgery, advanced imaging, infectious disease, and life-saving interventions. I would never suggest replacing those incredible tools. At the same time, whole person approaches can often fill the gaps, helping patients manage chronic pain, improve quality of life, reduce sleep, support recovery, and sometimes even prevent illness before it becomes more serious. The truth is, it isn't either or, it's both. One of the most common things I hear from patients isn't just that they're in pain, is that they often don't feel heard. They've seen multiple specialists, they had normal lab work, they've been told everything looks fine, yet they still don't feel well. When medicine becomes highly specialized, each organ system can be evaluated separately, while the person sitting in front of us becomes more fragmented. Whole person care asks a different question. Instead of asking only, how do we suppress the system? We also ask, what is the body trying to tell us? Sometimes the symptom isn't the problem, it's the message. That shift in perspective often changes the entire conversation between practitioners and patients. As we look toward the future of healthcare, I believe we need both scientific rigor and intellectual humility. We should be willing to study ancient healing traditions with the same curiosity we bring to new technologies. Not every traditional practice will withstand scientific evaluation, and that's okay. But neither should we dismiss generations of clinical observation simply because they originated outside modern institutions. The medicine has never been about choosing sides. It's about using every safe, evidence-informed medical tool available to help patients heal. If we can combine these extraordinary diagnostic capabilities of modern medicine with the wisdom of whole body healing traditions, we'll build a healthcare system that doesn't just manage disease, it helps people create health. Because ultimately, to restore the roots of American medicine, we must remember that healing is not the suppression of symptoms, it's the restoration of balance, resilience, in the whole person.